Associate of Medicine. And breast cancer is a topic that's near and dear to my heart because I treat a lot of patients with breast cancer. And it's one of the reasons that I went into medicine. So we have a lot to cover in terms of treatment. And instead of kind of doing a whirlwind of medical school, I kind of picked and chose a couple of key points that I thought would be interesting to share with you today. So the outline of my talk, I just want to give a brief background of breast cancer, kind of bust some of the myths that may be out there, and then just kind of basics on what breast cancer is, because we hear about it so often. Some of the current advances that we have, and future directions which are exciting. And importantly, I want to leave time at the end for discussion. So I'll stick around in case you have questions that you want to share with me personally, or you're welcome to share with the group at the end. So I'll definitely leave time for that. So the first question: what is the most common cancer in women? Is it actually breast, pancreas, ovarian, or lung? Any guesses? It's breast cancer. So breast cancer accounts for 1/3 of all cancer diagnoses in women. So this is the estimate, American Cancer Society estimate of how many new cancer cases there were in the U.S. Just in the U.S. alone, 1.7, almost 1.7 million people together, men and women and children, were diagnosed with cancer last year. It's a staggering number, and the number keeps going up. And there are some reasons for that, not all being that the cancers are becoming more and more aggressive. And we will get into the statistics a little bit, but this is 30% of all cancer diagnoses in women. But the incidence of lung cancer is actually going down, thank goodness, because of all the campaigning we do with smoking cessation. Men and women are pretty similar in colon cancer, and then there are the more rare ones. Ovarian cancer, although we hear about it a lot, is still a relatively rare cancer. So breast cancer is more common than you think. And how prevalent is it? Is it 1 in 4 women, 1 in 8, 1 in 10, 100, or 1,000? What do you think?
1 in 8.
That's right. So if there are 8 women in a room, there's 1 that has breast cancer. In fact, you probably know within your workplace or church a number of people that, or even your own family, women who were diagnosed with breast cancer. For men, in a lifetime, your chance of developing cancer is now 1 in 2. That's an amazing number. In fact, by 2040, cancer will become the #1 cause of death and the #1 chronic illness diagnosed in the U.S. Now, not all of them are the fatal kind. We know that prostate cancer, people kind of live with a slow-growing prostate cancer, although we don't like to hear the word cancer. It sort of lives with you. And then there are the ones that are almost universally fatal and very devastating, like lung cancer. We need to make more progress in that. For women, your lifetime probability of developing cancer is 1 in 3. And I've heard professors say that if you live long enough, you will get cancer. And it is a fact of life that as we age, cancers become more prevalent. And as you pointed out, breast cancer risk is 1 in 8. So it affects not only people that we are in contact with, but it doesn't discriminate. Cancer doesn't discriminate whether you're young and beautiful and famous and rich, powerful. This is Elizabeth Edwards. She died of metastatic breast cancer. And our Maggie Daley, Mayor Daley's wife, had a long battle with breast cancer for over a decade, and she succumbed recently to complications of metastatic breast cancer. So while it is the most common type of cancer diagnosed in women, it's not the cause of the most cancer deaths, meaning that we are actually doing okay, better than we were in being able to treat breast cancer. And there are a number of reasons why. Now, true or false? It is not possible for men to get breast cancer because it is a cancer that only occurs in women. False. That's right. That's false. And in fact, because of this belief, men don't get checked out when they have lumps in their breast because they couldn't possibly have breast cancer. I have a number of men in my own clinic with breast cancer, and they are hormone receptor positive, interestingly, meaning that men also do have estrogen. They don't want to admit it. There are about 300 to 400 cases of breast cancer in men per year. And so we do have to pay attention to men who have lumps in their breasts. So to summarize, breast cancer is the most common cancer among women. Over 200,000 cases in the US, but 40,000, only a fraction actually succumb to the cancer. 1 in 8 women will be affected. And the incidence is increasing, perhaps because we're getting better at finding it. But mortality is decreasing, and that's good news. So this is, again, statistics from American Cancer Society. And we had a huge increase in the incidence of lung cancer from sort of the 70s and up to 2000. And then there were campaigns for smoking cessation awareness, and as a result, the incidence and the death from lung cancer is actually decreasing, which is really great, but it's still way too high. With regards to breast cancer, we see that the incidence sort of plateaued, and then within the last decade or two, the death rates from breast cancer has been decreasing. We are making a difference. And the same thing with colon and rectum, and we believe this to be the case because we're finding this sooner. So with regards to colon cancer, there are more effective screening tools like colonoscopy and sigmoidoscopy. The other cancers that we don't really screen for, like ovary, pancreas, and stomach, we haven't made, or ovary and pancreas, we haven't made huge strides. We think that we made a big difference in the cancer deaths related to stomach cancer because of antibiotics. And a subset of stomach cancers are actually caused by H. pylori bacteria. And once we started to eradicate that, people stopped dying from it. So what is really, what does a breast consist of? So breast, as some of my patients have heard this before, is really a milk-making organ. It's a milk-making factory. And so it's really comprised of these lobules that make the milk, and then waterways or ducts that carry the milk out to the nipple. And interspersed in there is fat tissue, connective tissue. And there's really no muscle in the breast, only on the chest wall here. So when you kind of have breast pain, it's really not necessarily muscle pain or muscle strain. So the other part to appreciate that is that because it's mostly made of fat and connective tissue, no matter how hard you work out, you really can't make the breast kind of get more perky. They will head south at some point due to gravity. And then also, interestingly, we have these lymphatics that kind of drain the breast and any kind of tissue all over the body. It's a beautiful system that protects against your, it's a host defense against bacteria and other possible infections. So again, to reiterate, really you have these lobules. It's very simple. Lobules, fat, ducts, nipple, and then fat. And what we see here is that the most common place where you can get cancer is in these ducts. And when you read the pathology report, it will say infiltrating ductal carcinoma. That's really all it's saying, is that within these ducts, you have these cells that line the duct. It's really like a pipe. And some of these cells become abnormal. It is true that breast is a female organ, and as a result, it's under control and stimulation by estrogen. Now, estrogen has a lot of beneficial effects. Too much of it, probably not so good, but too little, and the fluctuations, you kind of know about moods and so on. But it is, for the most part, a protective and very good hormone. Estrogen keeps you young. It keeps the breast producing milk. It protects the liver and heart. Keeps you from getting atherosclerosis. Keeps your bones strong. It also regulates your uterus and so reproductive organs so that you're able to bear children. It's an amazing hormone. However, when it's not used in the right way, it can become very harmful in promoting cancer. So something that's very normal and good in your body can all of a sudden become something bad. And the same thing with uterus. The uterus is also under stimulation with, from estrogen and can, in some cases, the cancers can become even more potent under stimulation from estrogen. So it's kind of a double-edged sword. So, next question, what are the risk factors for breast cancer? Trauma. Some people talk about, they fell or somebody hit them on the breast and they got a lump. Implants, history of chest wall radiation, smoking, viruses, all of the above. So trauma is a myth, and you can't really get breast cancer from somebody hitting you. They're falling. And I hear that quite a bit, but it hasn't been proven at all. I think you can get like a bruise, but in terms of cancer, you can't really, it doesn't develop from trauma itself. And viruses can cause certain types of cancers. It's rare. Breast cancer is not one that's caused by viruses. Now, chest wall radiation, you would think, why in the world would you radiate your chest? Women who were treated in the 80s with mantle radiation for Hodgkin's disease were cured from their Hodgkin lymphoma, and then later on they developed breast cancer. And so we don't do that anymore. We don't radiate the chest wall without really thinking about doses for that reason. And smoking increases your risk of every single kind of cancer. They said that one cigarette causes 7 mutations. So if you smoke, please stop immediately. It's one of the best things that you can do for your health. Other things is age. As we get older, we become more susceptible to cancers in general. They found cancer in mummies, and it's just kind of a fact of life. There have been Egyptian queens who've had breast cancers and mastectomies, and we find these artifacts. It's been around for millennia. And then the other risk factor has to do with longer stimulation from estrogen. So starting your periods early, like some kids nowadays are starting at 10 and then younger at 8, 9, and then menopause like well into the 50s. So you have a longer duration where you're exposed to estrogen. Even though it's a very good hormone, it can have a double-edged sword. Having a childbirth is actually protective because when you're pregnant and having a child, your estrogen level is actually is well monitored. So having your child very late, again, prolonged exposure to estrogen. Radiation we talked about. And then BRCA1 and 2 mutation. So that's a genetic mutation. It's a very rare occurrence. And I showed you a picture of Angelina Jolie, who actually is a BRCA1 mutation carrier. Her lifetime risk of developing breast cancer is 80%. So only about 1 to 2% of all breast cancers are from hereditary causes. And even if you have some family members that have breast cancer, that doesn't necessarily mean that you're going to get it. And then hormone replacement therapy for the reasons we talked about, estrogen stimulation. But by and large, Cancer arises as a result of accumulated DNA mutation. As the cells in our body divide, because they have to, in order for us to sustain ourselves, even though we look like the same person, we're really not. We're constantly dividing and renewing ourselves. And as we do that, mistakes will happen. And over time, the older we get, the more mistakes and mutations we accumulate. And that's what we think causes all kinds of cancers. And breast cancer is no exception. So uncontrolled growth, and that's all that tumors and cancers are, is your own cells gone bad and growing uncontrollably. So there are many non-cancerous conditions in the breast too. So, now that we talked about like 1 in 8 women and all these things can cause breast cancer, and the older you get, now I don't want you to think that, I don't want you to become kind of like paranoid about everything that's going on in your breast. There are many women who have normal fibrocystic changes. This is normal. And I encourage patients to kind of get to know their breast. Even though it's a little intimidating, get to know the breast and see where you have lumpiness and thickening and swelling. It's normal. Not every lump means cancer. There are cysts. Some women have fibrocystic disease, and they really have lumpy breasts from birth. Fibroadenomas, which feel really like lumps, but they're not necessarily cancer. And infections too, mastitis. Sometimes breastfeeding women will get an infection of the skin, and it'll be really red and warm and sometimes lumpy. And trauma can cause a bruise, and you can actually feel it. I've had women come to my clinic who've had bruises and felt that they had a lump and were worried about cancer, but it really wasn't. And then if you read this on your mammogram, microcalcifications, it's a long word and it sounds scary. They're just tiny deposits of calcium that you can see on a plain film. Not all of them are cancerous, not a reason to panic. Majority of them are harmless. But there's something to follow, because over time, if they change, it may be a reason for a biopsy. So what are the signs and symptoms of actual cancer? The most common, of course, is a lump. And it feels like a marble. I mean, it's the consistency of something really rock hard. And often it's painless. It feels like you have a fixed marble or a rock under a blanket, and you're having a hard time moving it. Any kind of nipple discharge needs to be brought to our attention, bloody or not. The bloody discharge, you need to call your doctor right away. Change in size or contour of the breast, and sometimes people say, hey, my breast got bigger. My left breast is bigger than the other one, and that'll prompt a workup. Nipple inversion. So if your nipple is usually an outie and it suddenly becomes an innie, even though you feel nothing else than just a change in the nipple, that needs to be checked out. Change in color or appearance of the areola. There's something called Paget's disease of the breast, where there's kind of scaling of the skin of the areola. That also should be looked at. Then finally, redness or pitting. And when primary care doctors counsel patients on how to do breast exams, they talk about peau d'orange or orange peel skin. It literally looks like that. It's pitting, and the skin is really red, and there are these nets. And the reason is because the tissue is edematous. That needs to be brought to the attention of the physician. A lot of the cases that we see is actually called cancer, and probably is a misnomer, and there's a movement in our society to get this changed. And because it's not the cancer in the standard sense that it can invade and come back and metastasize or spread to other parts of the body. A lot of our breast cancer diagnosis are at stage 0, where ductal carcinoma in situ, meaning it hasn't really spread anywhere. And we talked about the duct anatomy. This is sort of the duct, the milk duct. And then you can have overgrowth of the cells that line it, but there's no actual breakthrough or invasion. And so this is considered a stage 0 cancer, which for the time being is included in all cancer diagnoses, breast cancer diagnoses. And there are various ranges of how abnormal these can be. And all ductal carcinoma in situ cases are referred to medical oncology for evaluation of risk reduction. So invasive ductal carcinoma, this is what we worry about. This is the kind that can break through the walls, the confines of the duct. It's a tumor that grows uncontrolled, and these abnormal cells can get into the bloodstream and then start to go somewhere else. And that's what we really fear when we talk about breast cancers. So invasive ductal carcinoma, the ones that occur in these ducts, the waterways, the milk waterways, that accounts for about 80% of all breast cancers. And the rest are invasive lobular carcinomas. They're the ones that occur in the lobules. That's less common. It's in about 20% of cases. And then what we see under the microscope is that these cancerous cells that have now overtaken the duct, they can spread and go into blood vessels and lymphatics. And the pathologist kind of described this phenomenon in the pathology report, and it's the medical oncologist who interpret this and then discuss its meaning with you. And it's the invasiveness that we really care about and want to control. So mammography has really led to early diagnosis and detection. And the most common breast cancers that we see now are stage 0 or stage 1. It uses a very low dose of X-ray to examine the breast. And even if you do not feel the lump, the mammogram can detect it. So it's a very important tool. And we have a wonderful women's center here. I've been very impressed by the radiologists and the technicians who run this women's center at Silver Cross. So let's say you get called back for a biopsy from an abnormal mammogram. So the chance of having a breast cancer at this point is 50-50. What do you think? True or false? Yeah, it's false. Actually, of all the cases sent for surgical biopsy, again, only 10 to 20% are actually malignant. So no need to panic. Take a deep breath. In most cases, end up being nothing. But we feel it's better to err on the side of caution. There's another movement to stop mammograms in women of a certain age. I think it fluctuates depending on who's in Washington. But at some point I heard 80, and I was like, well, that's kind of reasonable. And then it got to be like 75, and then as the Medicare costs went up, it was like 65, and I was like, oh, hold on there, 65 is still pretty young. So at the time being, I think Medicare is still paying for annual mammograms, and I do encourage everyone to go for screenings. And not let this kind of fear of unknown deter you. What can mammograms actually show? And it's really a black and white image. And it can show masses, and basically those masses are like shadows. They're like darker shadow than regular breast tissue here. And then we talked about microcalcification. And those are these little tiny flecks that you can see through an X-ray. And it's because there have been some areas of injury in that area, and so the body tries to repair it with calcium. So these subtle changes are what we follow. This is a benign lump, and then here we have a malignant lump, and you can barely see that difference. But if you look closely, there are these ugly projections, and that's what a radiologist, a skilled radiologist can read. So our guidelines currently, annual mammograms starting at age 40. That number seemed to be like eons later, but now it's here for me too. Clinical breast exams every 3 years in women who are in their 20s and 30s, and then annually. So this means by a physician, by your primary care doctor. Self breast exam, and this is very important. And the reason is because most breast cancers are found by the patient or by their spouse. And unless you know your own breast anatomy, you're going to think everything right now is wrong. But get to know your breasts, not to be afraid of the unknown. Some with genetic history should be screened more aggressively. Not necessarily more frequent mammograms, but perhaps a different mode of imaging. And that, again, accounts for fewer than 2% of the U.S. women. And in terms of treatment, this little pill, tamoxifen, has revolutionized the way we treat breast cancer. And as some of you may know, it's a selective estrogen receptor modulator. It's an amazing drug that has saved a number of thousands of lives. And nowadays, it's generic. And in remote countries, remote parts of the world where they don't really have standard medical care, much less access to things like chemotherapy, in places like India and Africa, women are given tamoxifen, and it is life-saving. And then we've gotten really sophisticated with things like Herceptin, which is an immune therapy. This is not your standard chemotherapy. This is an immune modulator that targets just that mutation. It's an amazing drug, again, that has revolutionized the way that we treat breast cancer. It's only been on the market since 2004. So I think there have been so many advances, and the reason is because of these clinical trials. And these are some of the I don't want you to read them, I just want you to get an idea of how many clinical trials are available. These are just the studies that are available through the University of Chicago. And the reason that we're able to make these advances and that we're able to make a difference is because women have participated in clinical trials and helped each other out. So, which of these will reduce your risk of developing breast cancer? 1, exercise, an apple a day, drinking red wine, low-fat diet. It sounds good. There's only evidence for exercise and low-fat diet, so red wine is not necessarily protective. Maybe for your heart, but not so much for breast cancer. So walking is great exercise, but you have to do a lot of it. You have to do at least 7 hours per week. So that's an hour a day. So vigorous exercise, and the reason is because your fat cells can actually make estrogens too. So decreasing that estrogen will help. And then a diet that's low in fat and controlling your weight. And obese women are at increased risk for something called inflammatory breast cancer, which is a more aggressive type. So I'm going to end by just kind of illustrating a story in the history of medicine. This is a picture of William Halsted, who I think is, they all have beards, but I think it's this guy here, who's a surgeon who was trained at my alma mater, Yale. And he was a surgeon in the 1840s, and these doctors are actually operating in their street clothes with some guy who's like holding a rag over this woman's mouth and performing an operation, and it's only 150 years ago. So there was like absolutely no knowledge of anesthetics or gloves or anything like that. And then Halsted started operating with, was thinking, well, maybe we should keep things kind of sterile, and started wearing gloves, and that made a big difference. But he was sort of a kind of a hero in his day for developing novel therapies. And his therapy, the Halstead method, took a woman with a lump in the breast, and this was the type of morbid procedure that was performed. And compare that now to 100 years later, where we really do minimal surgery to do a tiny lumpectomy and a tiny lymph node removal, and I think we've come a long way. So how have we made a difference? Well, this is a 5-year trend in cancer survival rates within my lifetime, so from 1975 to more recent. And here's breast cancer. For women who are diagnosed in the 70s, your chance of making it 5 years past your diagnosis was 75%, which is pretty good, even in 1975. And every decade, we've made a difference. 84%, currently 90%, and in 2010, I heard greater than 95%. So, this is why I'm a medical oncologist. This sort of thing makes me excited. And it's because of the efforts of not just the doctors and the scientists, but women like you who participate in clinical trials, raise money for cancer research. It's really made a difference. So with that, I'd like to thank the organizers at Silver Cross Hospital. I've been here for 6 months and really feel welcomed here. I appreciate this opportunity to meet with you. And the University of Chicago Comprehensive Cancer Center. It's really a privilege to take part in research and be part of that community. And I feel like every day I'm just so lucky to be able to have the job that I have. And most of all, I'd like to thank my beautiful patients who inspire me every day. And that's why I do what I do.